Hi, good morning, and welcome to Fridays on the Porch. I am your host, Dr. Katie O'Shea, and today is a very exciting Friday because our official Friday on the Porch merchandise is here and cups are here today. So we're real excited about that. And we're very excited about our special guest today, Chris Bowen. Chris, welcome. So good to have you.
Thank you for
Cheers.
having me.
Thanks for being on the show.
Absolutely.
Chris and I worked together quite some time ago at another company. I was on the assisted living side. He worked in the hospice department. We've maintained a professional friendship, and Chris will give you a little bit more about what he does, but really wanted to talk about the opportunity for hospice, what it is, what it isn't, kind of clarifying some of the myths and things that kind of keep people fearful in living their best life, even on the end of life. So, Chris, welcome. Thanks so much for being here.
Thanks for having me, Katie. I'm excited to be here.
And we're really hoping for not a technical error with our new mugs and you watch us drink coffee with our faces, because that is absolutely something that would happen on Friday on the porch, without a doubt.
That's awesome.
And I'm going to take the first sip and tell everyone about yourself a little bit.
So I've been in hospice going on 8 years. I've had a couple of detours through the past and worked for a lot of big companies. My most recent now is Gentiva. We're under the Heartland brand. My career path is kind of a little different. I started in technology in the mid '90s, and I grew up out west and kind of traveled around and did a bunch of different startups and a bunch of different cool different things. But I never really had a passion for it. And right around 2012, I met my wife. She's an occupational therapist, and
Hi, Jen.
hi, Jen. And I was trying to find out where I was going to go. I didn't pick my last career, so I wanted to pick the next one. And I knew is I wanted to do something that impacted people in a positive way. I was at the point in my sales career where I couldn't sell any more widgets, or euphemism for anything really. I wanted it to make impact, and I didn't know what that was, because I'll be quite frank. I'm like the general public as far as before now, I'm a family guy with the kids and everything. But before that, I went to the doctor probably only when something was either broken or felt like I was going to die. And we didn't, so
Literally.
the ER. I didn't even have a primary, to be honest with you. So I'm probably like a lot of our clientele, right? Yeah. So
we're very grateful Jen kept you alive.
Yeah, things are different now, but I didn't know much. I didn't even know there was. Well, funny joke was, when my wife met me and she told me she was an occupational therapist, I didn't know what it was. I thought it had something to do with finding work and jobs. I'm like, yeah. And then I Googled it. I still didn't know what it was because I wasn't that bright. And so I've learned since, and I won't discourage her career. But so after that, what happened was my grandfather went on hospice. He was on dialysis, and I was the POA, the contact for it. And I was like a lot of general public. They asked me if I wanted to put him on hospice. And I'm like, heck no, I don't want to kill him. Are they going to give him some morphine? The guy's never done a drug in his life. And are you going to make him an addict? You're going to kill him? Those are things, back to what you were saying about myths of hospice. What is it? And so in that situation, I did put it off. And with dialysis, if you're familiar with that, that prognosis is that you're pretty exhausted if you're not getting it. So then you spend all day getting. So there was 1 or 2 days a week where he was declining, and we had a little interaction. But he quickly went to 4 days a week, and that was the end. I never really got to say goodbye. It never, it was kind of a pretty drastic end. He was being treated until he passed away, which is a lot of the general public and a lot of the data that I have. And what I found is I did last minute put him on the hospice benefit. And for my big Irish Catholic family, who's doesn't know how to do much except for drink and fight, it kept our family together with the 13 months of bereavement care that we obtained from the benefit. So we didn't get the large. My grandfather didn't benefit from it, but for me it was like, okay, now where's the catch? There's always a catch. You're not going to just come to my house and be kind to me and help us and do this. Where's the bill, right? Because I'm practical. I'm not a clinician by background, as you can tell, and it never came. And the people that affected our lives affected us in a positive manner, and I realized that was my passion. And that's where I dug in. What is hospice, and why isn't everybody taking advantage of it? Why is an educated person, if you want to call me that,
we'll give you
not knowing what's available to us? And that goes to the hospitals, the case managers. He lived in a CCRC, you know, and they had it, you know, all levels of care. Not one person explained to us in a confident manner what hospice was. It was, do you want it or not? And when I had misbeliefs, so I've made that my passion. So that's a little bit about why I'm here, and I think I can really kind of dig in and help people connect the dots, because I think there's a lot of misunderstanding of what the hospice benefit is and how it benefits not only the patients but the families and the communities that we live in.
It's true, and that 13-month support post grief, I think, is huge, right? The first year and a month without. I mean, I think about things, even not the death of a person, sometimes death of a job, a relationship, all those different things. Well, those aren't hospice categories, right? Grief is grief, and those are things that we can learn and take with us into those things. I mean, certainly in my career in the hospital side of my PT life, I see patients dying tragically, painfully, and families not understanding. And the conversation still is, hey, do you want hospice? And people go, no, I don't want him to die in 3 days, right? And that's, I still, 2024, still see that as one of the biggest misconceptions. So what exactly, like, how would you describe hospice? If I came into your office and said, my dog's dying, I wouldn't be well, let's be honest. But how would you describe hospice to me, or like your loved one's dying?
Well, a lot of times people feel that hospice is kind of a catalyst to death, and really what it is it's actually the entire process of having a good end of life. So you're once you become part of the benefit, you're no longer expected to go to any other level of care. Everything can be handled in whatever home setting you have, whether it's assisted living, whether it's your home, whether it's a long-term care, or what, et cetera, et cetera. And what we do is interdisciplinary team of a medical director, a social worker, bereavement coordinator, volunteer, and I'm missing a couple there, but there's social worker, nurse, obviously, and the aides sit down and weekly or bi-weekly go over your care plan and discuss kind of your decline and where that's headed, and also manage those symptoms. In the benefit, you're guaranteed to have a nurse visit once every 2 weeks in your home, an aide visit at least once every 2 weeks, social worker visit once a month, bereavement once a month, et cetera, et cetera. I think that's your bare bones benefit. And where hospice really takes off is that's not a lot of time for somebody. It's going to only last a few days, right?
Right.
The benefit's designed around somebody that's going to live 6 months or less. Generally speaking, if hospice is done right, you're looking at that or longer. I have a lot of patients that actually graduate, but the average length of stay, and the records change constantly, but was on average about 14. Length of stay is how long people are on the benefit. And you got to take, there's some long timers, there's a lot of short timers. It's about 14 days on a 6-month benefit.
Wow.
So when you're seeing somebody once every 2 weeks or once a month, so you know, my agency that I'm an administrator for I have a couple agencies in South Jersey, and in my team, we see our nurses go out twice a week. Our aides are usually between 3 and 5 days, and almost on average 5 days right now. We're probably 4.7 because there's a couple that don't want our services.
Not to get exact.
Yeah, well, I keep track of that. I'm also a big nerd if anybody's ever met me.
He's not lying.
And,
doesn't own a stapler.
Yeah, well, that's true. I don't have a printer anymore either. I don't know how to use it. But that, you know, and so that's basically what. So what we do is we manage your symptoms, make sure you're not in pain, make sure you're comfort, make sure that your psychosocial's handled with psychological and with bereavement, and that's your family and your entire group or your lifestyle. And so we want to make sure that your house is in order. So we make sure that your pulse is done, that your you know, whatever your directive, we really focus on pulse in New Jersey, which is your wishes as the patient. Generally speaking, you want to have that in the home. And you know, I'll go into detail, but like we make sure that these people that are in our care in hospice have all their ducks in a row. And it's interesting because in our society, we celebrate birth every year. Every year we talk about our birthday. In fact, some people have birthday month, birthday quarter, you know.
Half birthdays, quarter birthdays, yes.
I'm at that age where I don't celebrate.
Okay.
No, I'm just kidding. It's only because I get forgotten in my house full of young kids. But,
that's called dementia.
Well,
good thing you have an OT as a wife.
Yeah.
Jen,
yeah,
we're worried for you.
Yeah, well, she's worried as well.
But you're right. We always celebrate birthdays, and there's such a negative around our last birthday or end
Consider a
of life.
milestone, yeah.
Yeah. And it doesn't have to be, right? And there is a death with dignity, and the POLST, right? The what's physician order of life sustaining treatment.
Thank
Is
you for
that
that.
okay? Digging back in that memory
Thinking
bank
like I
there.
remember a word or two.
Yeah. And now that reminded me, that directs your medical care. But isn't there another document that also directs kind of the softer care, right? People who want maybe different, like the five wishes. Is that it?
Yeah, that's part of it. So that's
Like
part of any admission.
smell.
But yeah.
Okay.
So when we admit, that's part of the question. You know, a lot of that, unfortunately, a lot of our patients are not able to make those decisions. But we do ask that. The social worker goes over with the family, what does your loved one think? But usually it's, you want to ask the individual. And PULSE is another one, right? The only legal document for your care that the entire healthcare system has to follow is a PULSE. A lot of people feel advanced directive.
Yeah.
They feel, living will.
Right.
Those are absolutely great documents for legal. But for healthcare providers, a doctor, if you have a pulse, usually put in a place where, the EMTs will see in a bright color, ours is orange, they'll take it to the ER. And if DNR, DNI, whatever it is, will be on there as well as any other documentation. They have to legally follow that document.
Okay.
And it's really important because I think in crisis situations, family members will panic and they'll be like, they don't let them die. But if I know for me, I don't want, just let me go, and I want to go in a peaceful manner, but not everybody feels that way. So that's a wonderful part about it. I'd say the other question you asked is, what are the pitfalls with hospice?
Mm-hmm.
So in the United States, we only use, and this has been pretty steady, hasn't fluctuated much since the mid 90s. And now keep in mind, this benefit's only been around since 1983.
Oh,
yeah,
40. That was the year I was born.
Yeah, there you
All
go.
Right. Can't tell because
I was way past it.
Yeah.
I'm like a grandpa here now. I
remember the 80s,
like
chair.
It was great. Yeah. But it's only been 48% of people that qualify for the benefit, which is pretty much every single person in the United States, utilize it. That's a lot of people that die without any benefit. And what do we find when we research it? We research that a lot of it has education. So me trying to figure out how to fix the problem and connect the dots goes, well, why aren't the doctors explaining it? Why aren't the case managers and social workers, right?
Yeah.
So you blame them. But that's not really fair because everybody is completely booked. Doctors don't have the capacity. They have to turn out patients. They're not allowed to go to your home. And as a patient declines, they go home less and they go to the hospital more. Case managers, discharge plans, very difficult, time consuming. They not only are they unknowledgeable, but if they are knowledgeable, they don't have the time to have that conversation to go, listen, you came here for an emergency to help you.
Right.
And now we're going to tell you your mom or dad or your loved one is going to pass away. That can turn into, and I have had this conversation several times, to a 4-hour conversation. That's a half a workday for a case manager that has 40 discharges for that day.
Right.
So
with a productivity standard of 70%, or
exactly. So generally speaking, that conversation, difficult families, the lack of knowledge, and just how do we get the easy button to get these people out of the hospital so we can help more people, gets that conversation and backburners it. I go to a doctor. You think you're primary. I gave you an example of myself. I didn't even have a primary, right?
Right.
But if I did have a primary, he generally is not going to see you in a time and capacity in your life where you're going to have that end of life conversation.
Correct.
Right?
Right.
If he's knowledgeable about it in the first place. And a lot of doctors are. So how do we do that? So my job is, of course, to give excellent care, make sure my team does that. But, historically it's been on the business development side, and I really have turned that into my administrative operational side, is how do we get the care to more people?
So how?
In our world, we look at hospice as a competitive environment. I think we're in Burlington County here in Medford. There's 37 providers. Last I checked, that could be off by a few. Anybody's holding me accountable.
Wow.
That's a lot.
37 providers
37
in just Burlington County.
Just Burlington County. Camden County goes a little bit higher. Philadelphia can go up to 60.
That's wild.
There's a lot. And there's a lot of small ones. There's a lot of different things going on. And you're seeing a lot of different trends. SNFs are producing their own hospice providers. They're trying to keep their patients on their services and their partners. And understandably, these are all great strategies. But what we need to do is we have to figure out how to connect the dots to get the people on the service. And as I said, we need to get them on the service and longer.
Right.
I love recently as far as education goes, it comes down to how do we manage if we're doing a good job in hospice? Because generally hospice is, I went to the doctor, he's curative, here's your magic drug, this is our magic cure, this is our PT or OT, we're gonna give you home care. So they're easy buttoning it to home care. So that would be either your Medicare home care, which would be your skilled care, right? Discharging out, which you're very familiar with as a PT.
Home care, yep.
And then there's palliative is another discharge plan, and then there's non-clinical home care. What we're seeing is the industry is that a lot of social workers are discharging in the SNF setting and the hospital into that home care bucket, expecting most of them are tied, and the SNFs are also tied to hospice, that they'll get in the right level of care down the line.
That'll just magically fall into place.
So I get off my desk, push it down. It makes sense, right? Like if I have a home care, like we get at Morristown and a hospice, then what I could say is put them on our home care. We'll make sure we give them the right level of care.
Right.
And we've got palliative in between everything. So that's great, except for when you look at the numbers, and I've had the ability to work for companies with large home healths that are tied to hospice. It takes up to, because you have the started care, you have the assessment, the eligibility determination, and then you're scheduling your visits. Those people can be on after discharge, after started care, for 12 to 15 weeks.
Wow.
When you're talking about hospice being a 14-day average benefit, and some people are saying 9 in the most recent studies.
Wow.
Look at all that time that person could have been on the right level of care, could have utilized those services for the home health and for other people that needed it. Because the other startling statistic that I see constantly throughout the nation and all the data, and even locally in New Jersey, is that 40% of the discharges out of hospitals are getting zero care. Right?
So home health as well, nothing. Just goodbye.
No private duty. See you later. Hopefully you make it.
Wow.
Right? And then you're like, well, Chris, when I chop my hand off with my chainsaw, I don't really need all that other stuff. I just need a Band-Aid or whatever the situation. Yeah, there's a lot of that. But what I'm seeing is I have Medicare aggregators. So this isn't people with private insurance. This is 65-year-old people. So this is probably, I don't know, up to 2/3. It's probably closer to half of the patients that go to any average hospital in our area. There's about 8 of them.
Right.
Are
and
being
this is a population that's only growing.
Like growing and growing. Silver tsunami, as we all know in the industry. You're seeing that the recidivism, that's a big word I shouldn't have used. I should have said rehospitalization, in the 30 days on those 40 people is up to about 35% in the first 30 days.
Wow.
And then in a 90-day window, which are Medicare guidelines of rehospitalization and manage those things, so 30 months out, so they either have been in a post-acute setting or whatever, those people are coming back in around the 22%. And that's a standard New Jersey rate and a national rate. It's right on the nose.
That's a lot.
Isn't that a lot?
That's a lot. I didn't realize that.
Yeah, it's a massive amount. So what does that do?
And that's a huge payment penalty for the hospitals and health systems.
Huge. So your star rating, if your SNF gets affected, star rating is about, your ranking as far as your care, your reimbursement rate for Medicare. It's financially out, it's a private business, right? So the other interesting thing is those people, okay, maybe they're going back to the hospital. Maybe they got an infection. Maybe we should have put them on home care. What I'm curious about on the hospice space is, I shouldn't be doing that. Right? What I'm curious about in the hospice
space is,
can't hear the truck over here, his pants. How many of those people were probably eligible for the benefit, but were put on the wrong level of care and maybe weren't given any level of care? And so I just did I won't even name the hospital, but I just went and had a meeting with the C-suite yesterday, and they were seeing in the last year on just that segment, that's people discharged out on Medicare, and within 90 days, they had between 300 to 400 deaths, depending on how you look at the number. That's a lot of people. They discharged over.
Out of how many? Yeah.
If I'm going off of I think it was 3,700 in a 3/4 span of time.
That's a high percentage
in that segment.
In one hospital.
And that's one hospital in that segment, because you got to remember, there's a lot of people going to home health. There's a lot of people getting private duty. There's a lot of people going to SNF. So that's a lot of people. So back to the competition. 37 providers in Burlington County. Right. Am I really competing with somebody giving great care? No, I think we're all allies trying to get the word out. Right. And, maybe we're a different brand. Maybe we have different allegiances. But my true strategy is, how do I get to the 52% of people that need that benefit?
Yeah.
And generally speaking, if I look into that, which when I looked into this benefit and what I wanted to focus on, and I'll stop talking.
You're okay.
Socioeconomic people. Those are the poor people. Those are the people that have nothing. In our area, in Camden County, we got a lot of underprivileged areas.
Mm-hmm.
Those people get zero attention.
It's true.
Right? They're
Right.
mostly Medicaid.
Mm-hmm.
They manage Medicaid. Those are people where like I'm not going to get anything from treating you, so why put the effort to doing it? And it's sad. That's the business of health, right?
And we think healthcare literacy is a third grade level. Understanding is a third grade level, but these diagnoses, conditions, and navigating through the healthcare system takes such a higher level than that.
Right.
And people just get lost.
They get lost
Mm-hmm.
and they get overlooked.
Yep.
And you have barriers in language, you have barriers in meeting them where they live,
Right.
and these
Cultural needs.
Yeah, a lot of cultural needs.
Mm-hmm.
I mean, that's just more and more what we see. So that kind of goes into a whole nother category. But what we see in that area is they're underutilizing the most with the most need. Those people are generally have not a lot of safety net, as we
Right.
understand.
Right.
I mean, that's a pretty good understanding. And Medicare, for anyone over 65 as a U.S. citizen, we all get it.
Right.
Why are they not getting the benefits to their family, keeping their family together, getting that aid? In that world, if you have the elder, or hopefully it's an elder, right, and it's surrounded by a family, and people are working minimum wage jobs or maybe low-paying jobs, they can't afford to take that time out to take care of mom and dad.
Right.
They can't afford to pay for that private care. They can't afford
to call off.
Exactly.
Right?
I mean, we all know that situation. I know I came up that way. It's a difficult life.
Mm-hmm.
What if I came in there and said, listen, I got hope for you? A lot of times, it's brought to them last minute. Hey, mom's going to die. You want to get to service? And they're like, whoa, wait, and they're going to think. So our job is to educate.
So let me ask you a question. As a PT, as an OT, speech, nurse, all of your non-prescribing providers, is there a conversation we can have when we're with patients?
Oh, gosh, yes.
Is that a loaded question? I think
No.
we only have like 10 more minutes, so.
No, I don't think it is. I'm sorry for dragging on.
We love this. This is a great content.
I really feel that is probably a key part for you to help out.
Mm-hmm.
And another thing with to go down the avenue for you is, as a PT, my wife's an OT, we talk about it all the time. We're very boring people to be friends with because we talk about the post-acute network and how it works and that life. And we don't have a lot of friends. So
because we analyze their gait and their ADLs. We're real nerds.
and then somebody will go up to me and say, what do you do for a living? And I say hospice, and they walk away. And my wife's like, every time you say that, they walk away.
Yeah.
But it's fun.
Yeah.
But what it comes down to is
what they tell you.
Sooner you can interact and educate somebody on something, especially something you're not sure about, whether you bring in somebody as an expert, whether you say, hey, listen, you should look into it, they're going to take you, who they haven't seen anybody who is been an advocate for them, and take it for it. Mm-hmm. They haven't seen their primary, right? You've seen it. They went to the hospital. Nobody had time for them. They're just trying to push them out. Right. Now they get to spend time with you every week, right?
Right, especially home care, outpatient,
as
mental health counselors.
Exactly.
Yeah.
All it takes is, listen, this is where I see you're going. I'm going to help you. I'm going to try to get to where you're going. But when you get to that point, this isn't something you should be afraid of. This is something you should find out more about. You should be interested in hearing about. And they're going to take your word as a doctor of PT, as a person that cares about them, that's willing to listen to them. They're going to listen to you. Because they're kids, just like I was with my grandfather. They're not going to know what's going on.
Right. And you're in crisis mode. Right. You're hearing 10%, if that much, of a conversation anyone's having with you anyway.
So you're an advocate.
Yeah, definitely an advocate. So for clinicians that aren't familiar with hospice or have their own barriers, fears, right? Death is scary.
Yes.
What would be like a one-line sentence, a script you would provide to them?
Oh, yeah, no, that's interesting. I got to be honest, there is...
You can have 2 lines.
No, it's an elevator speech for hospice is a very difficult thing.
Right.
And there's other avenues around it, and it's really like, I think you got to take the real holistic approach. Actually, that's what you do.
That is what I do.
But you have to treat the entire person and be like, listen, I'm going to, in your case, get you to walk, get you to go do whatever your goals of care are, and just go, listen, I think you're going to do okay, but we both know you've been in the hospital 3 times, in the last month or whatever. You know that we don't have a lot of services available, and I think that you deserve the care that you qualify for. Hospice, you could say hospice, or you could say end-of-life care, or you could say, another level of care. You don't need to be direct because you're not giving the referral. You're educating the person.
That's the difference. Yep.
And that's the difference. And that's where you make all of it. Don't use the H word, right? that is a barrier that I hope that one day we get past, and get that stigma. And a good example of that is, as we said, the short length of stays, the 2 days you use, right, which is not too far off of accuracy, depending on your setting, especially a hospital setting, right?
Yep.
Or for me, the 9 to 12 to 14 days for length of stay. Look at Jimmy Carter. Jimmy Carter's been on hospice for a year. Does Jimmy Carter get a different benefit than you or I?
Well, a little.
Absolutely not.
Doesn't he have a different benefit from being president?
No, he probably has a security guard.
I thought they had really good benefits.
No, well,
all those government folks.
We do. We get the government program of Medicare.
Huh.
And Medicare covers the hospice benefit, the same for you, the same for the person in Camden, the same person that's Jimmy Carter, our ex-president, peanut farmer.
Huh.
And
a little bit of ignorance on my part. I
I
thought it was a different Medicare for the...
No, a special Medicare for the politicians?
Sure did, not going to lie.
No, it's wonderful. It's a benefit that is only increasing. If you look at the business of healthcare, cut, more rules, more that, not hospice. They see the benefit. Because if you put people on the right level of care, especially hospice, you can't fix them. As much as we want to, they're ready for life. They're going to stay out of the system, so the people that really need the care are going to be able to get it.
Yeah.
And that's my mission. Empty those people that aren't supposed to be there. Get them out of the way so we can help people that really need the care and get the experts they need.
I love that. So I think about people that have been on hospice. Clients that you and I have shared in the ALF transition to hospice people, to the hospice program. There's still sadness, right? And there's still grief. And so I think another myth is, hospice maybe won't make it as sad or as scary, and that's not the case at all, right? But it's more you are supported in that grief process, in that what to expect, what death looks like. Do you have any case samples or scenarios that you can think of where hospice just really brought the family together or gave them a improved quality of end-of-life experience?
Yeah, I would say every single case.
Okay, well, we don't have enough time for all of
I'm
that.
not going to give you that, but I've given you my own personal case already.
Yeah, you did with your family.
There's so much beauty. I wish you would have prepared me. I would have given you an example.
I just came up with that.
No,
that's the fun of uncut, unscripted on the porch.
No, I know. It's
He's never quiet. This is great, everyone.
I don't want to speak up.
Yes.
I think if you look, I think the best thing is I'm a stats guy, right? So I want to see. If you look at, we get surveyed for Medicare, and so does home health.
We all do. We love our surveys.
Love it, right?
Put your water bottles away.
Right. And what you see is the patients that have the mortality on the wrong level of care, whether it's in a SNF with CMO, which is GIP in a hospital, or whether they, whatever. Those people's families did not have a good. They generally, their scores are lower. They don't say any surveys are not great. And a lot of times if they die in your service, especially a curative care, they're not going to go on Google and say, I had a wonderful experience.
They're sure not. Nope.
But when they do go on hospice, and hospice is done right, whether it's my provider or somebody else's, those reviews are ecstatic. And I get to see it not with my own patients, but with my own community, which I love. Is I will always, not today, so it's a bad example, I'll always wear my hospice brand, always says hospice. And I will go more places and never have one interaction that isn't a positive thing where somebody will stop me and say, thank you. And I have to actually give all the credit to clinicians, but I'm like, they will cry and hold my hand about the benefit.
Yeah.
I can give you, I just went to a baseball game and I went with the team and I was wearing a hospice shirt and somebody just, one of those really hardcore Philly, crazy, throwing snowball. I'm just kidding. But like those kind of guys stopped with his beer in his hand, goes, you're an angel. I go, I'm not, but I appreciate the sentiment because I really do. I'm glad that you had a great experience.
That's a beautiful thing. Just those little moments where you get to take down that stigma and create some positivity for folks, supports in their lives that help to decrease stress and improve optimal living. Certainly something that I love in my role, and I think all of us together, it's what education, exposure, understanding of what things are. Perfect. So, Chris, if people want to get in touch with you,
Oh, absolutely.
Can they? Do you under your rock or?
No, actually, I don't have a job. No, I'm just kidding. I'm so lucky. But I work for Heartland Hospice, where we cover the entire South Jersey area. We're a national provider. We have 38,000 patients on service now under the Gentiva brand of hospices. I think there's 9 brands now, but in our area, it's Heartland. We have the largest home health, not in our area, but throughout the United States. The largest palliative independent program, and I love to talk about that sometime, because
That
that's
could
really
be
my
part two.
wheelhouse. Yeah, and we have the also the largest hospice as far as patient goes. But we cover all of Jersey now. Actually, we're opening 2 more offices, but by the end of the year, we'll cover the entire state of New Jersey.
Wow.
And all of Pennsylvania, Delaware, and throughout the entire East Coast. You can always contact me at our local office, or we have lots of business development people that are out in their communities trying to connect.
Perfect.
But I appreciate it, and I appreciate what you do too. So
Thanks.
thank you.
Oh, my pleasure. And I'll link all of Chris's contact information in our description. And thanks so much for spending Friday morning on the porch with me, Chris.
Absolutely. Thanks for having me.
No, my pleasure. Glad we didn't cover ourselves with coffee. And I hope everyone has a great day.
You too.
Take care.
Cheers.